Good evening and welcome to a joint webinar between RapidAI and Code ICH. My name is Dan Actor, and on behalf of the entire RapidAI and Code ICH teams, we want to thank you for joining us this evening. It's an honor to have such a distinguished physician, researcher, and leading voice in ICH patient care with us today. Dr. Stephan Mayer is a neurologist and critical care physician who currently serves as Director of Neurocritical Care and Emergency Neurology Services for the Westchester Medical Center Health System. He is also a founding member and past president of the Neurocritical Care Society and a founding member of Code ICH. In this webinar, Dr. Mayer will explore the evidence regarding current diagnostic approaches and treatment strategies for ICH and the impact that AI can have on ICH decision-making and patient management. At any time during this presentation, we encourage you to submit your questions in the box on your screen. And without further ado, I'll hand it over to Dr. Mayer to help us learn about ICH in the era of AI. Thank you, Dr. Mayer. Take it away.
Thank you, Dan. And I want to thank everybody that's online tonight to attend this seminar. It's a great honor. I just want to start by emphasizing that this is really a magic time in the management of intracerebral hemorrhage, the most deadly form of stroke. And we're really right now cresting in terms of all the promising capabilities that we have now at present, which I'm going to talk about. And I'm going to talk futuristically about, where is this going to go? So let's get started. So I'll tell you a little bit about myself. So this is where I work. You see the red star, that's Westchester Medical Center in Valhalla, New York. It's about 15-ish miles north of New York City, actually. And you see shaded here, this blue region right above to the north and west of our medical center. And that's our catchment area. So we serve a really gigantic catchment area of about 2.5 million individuals, which is actually kind of a little starved in terms of expertise regarding neurologic care and especially neurocritical care and neurosurgery. So our catchment area is basically about the size of the entire state of Connecticut. And my colleagues and I have been thinking for a while about how can we improve ICH care, the level of care, the standards of care, and the outcomes. And that's actually where the whole Code ICH concept comes from. And I'm going to tell you a little bit about the origin story of what Code ICH means and what kind of directions can we go into. These are my disclosures. And this is a picture of an intracerebral hemorrhage. And it looks pretty nasty, right? You can sort of see the angry, red, inflammatory reaction of the surrounding brain tissue. We call it perihematomal brain injury. The blood is toxic to the brain. And the longer it dwells within the brain tissue, the more there are inflammatory mediators that leak out into the surrounding brain tissue. The blood clots, and then this plasma rich in thrombin and other coagulation end products soaks into the surrounding brain and triggers this destructive neuroinflammatory process. Typically, it's not ischemic. It's actually inflammatory, but it triggers tissue inflammation and programmed cell death. And it's nasty. And that's why ICH is such a devastating cause of stroke. 15% of strokes are ICH in Western countries, but it may be as high as 25 to 30% in Eastern countries in Asia. The mortality rate has really not wavered below the historic benchmark of 30 to 35%. And if that weren't bad enough, with all the mortality that you see, the functional outcomes are way worse than in subarachnoid hemorrhage with all the good grade patients and in acute ischemic stroke with so many of these in small penetrator infarcts. We've been looking forever for a magic bullet kind of treatment. Factor 7A, for instance, in a hyperacute phase of bleeding shows promise. It can actually reduce hematoma expansion. Still hasn't really passed the test, though, in terms of proving clinical efficacy, and that's exactly what's being tested now in the NIH-funded FASTEST trial. The role of surgical evacuation is evolving, and I'll talk a little bit about that and about the historic ENRICH trial showing promise for minimally invasive surgery for larger lobar hemorrhages. However, there's been a lot of comparative effectiveness research showing that ICH patients, when they're cared for in a dedicated neurological intensive care unit, when you observe what's going on out there, tend to do better, die less frequently, and have better functional outcomes treated in these specialty units than in general scattered around the hospital on medicine floors or surgery floors or something like that. My own feeling is I think it's that kind of sense of dedication, hopefulness, and implementation of the little things, the supportive care, the best clinical practices that we do know about. And what we're talking about in Code ICH really is about codifying and bringing the same rigor that we are all used to now for acute ischemic stroke and bringing that over now to ICH, which I call the redheaded stepchild or the orphan stepchild of stroke. And there's different reasons for that, but one of the reasons I think is that many stroke programs have extremely robust quality assessment programs. And there are quality metrics, and they're measured constantly. And we're all being called to these monthly meetings to look at our stroke quality measures. And the hospital executives are interested in this because they're paying the salaries of the stroke coordinators. But historically, there's been a lot of focus on the AIS, acute ischemic stroke, not so much on the ICH. And there's the issue of ownership. Who really owns ICH? But most people don't get operated on. It is a form of stroke, but most stroke programs have historically focused on ischemic stroke, and for good reason. There's been amazing breakthroughs in thrombectomy and everything else. Neurocritical care, yeah, but even neurocritical care, is well established as it is now, I think is kind of running to the forefront here of ownership of this illness. But I think that historically it's been a little bit poorly defined. So a group of people, including myself, and I want to acknowledge Josh Goldstein. He's an emergency medicine physician at Mass General. We collaborated on this Code ICH paper. And this is a figure from the paper. And what we're trying to do here is draw out and point out some of the disparities. So acute ischemic stroke, imaging. Well, the imaging is fantastic. And, I think that RapidAI and other types of companies like Viz.ai really deserve an incredible amount of credit for bringing this technology into the clinical sphere. So now we take it for granted that we can detect large vessel occlusion strokes, not only in our own hospital, but throughout our systems. And we can use that to triage people to come urgently down to the thrombectomy capable or comprehensive stroke centers and have the team waiting for them to do thrombectomy. I'm going to talk about the imaging for ICH. And we say in the figure, well, so far it's somewhat inconsistent. We've got some interesting, kind of promising findings with, say, spot sign on CT angiography. But really, we are, again, cresting as a work in progress in ICH. Although the future, I will tell you, I believe, is extremely bright. In terms of blood pressure control, we know ICH patients present with the highest blood pressures you're ever going to see in clinical medicine. And we've got fairly well accepted guidelines for how to control blood pressure before and after thrombolytic therapy and by extension endovascular. We've got the clinical drug trial data I'm going to talk about how to manage blood pressure in ICH, we've got this idea of this target of 140, as long as you're not extremely hypertensive, but we've never had kind of door to needle time metrics for when to start parenteral agents for blood pressure control. As a stroke center, no one's holding you to task, right? No one is measuring how well are you doing at this. And we also need more data on which agents are most effective. I have my opinions, we'll talk about it. Hematologic therapy. Well, we're going to talk about thrombolytic therapy with TNK or TPA. It's well established in acute ischemic stroke. 4.5-hour window. Some interesting new studies looking at using imaging to select patients with a last known well that's unknown, maybe extending that window. But there really have been historically no standards at all when people are on blood thinners and are bleeding in their brain. No real standards for how quickly we need to give it. We don't measure it, and which agents to use, which I think is an even more aspirational goal. Then in terms of surgery, well, endovascular therapy, thrombectomy is clearly the standard of care now. There's, questions about the MEVOs and the DEVOs and how are we going to fix that? The time window has been expanded using CT perfusion again. Incredibly helpful to have applications like RapidAI that can, calculate penumbra volumes and core volumes. But the role of craniotomy and surgical intervention for ICH is still evolving, a work in progress. This is a slide I went and did some research, and I found a hospital upstate New York, a hospital that actually we serve as a quaternary care center. And I wrote down a list of all the different stroke-specific performance metrics for acute ischemic stroke. And you see a bunch of them are time-based. I mean, not only intervention with antithrombolytics or et cetera, or, picture door to puncture time, how quickly can you get a TICI 2B within 2 hours? Same hospital. And I'm going to show you now, here's their ICH metrics, right? So there's an imbalance. There's a disparity, right? We know there's more ischemic stroke than ICH, but probably both diseases kill the same number of people at the end of the day, right? And okay, give some reversing agent, whatever you want, whenever you want. And, so the thesis is we can do better. And I had some personal experiences dealing with ICH patients. And, the typical story is everyone's ready, a stroke code's called, pharmacy's there, we're ready, the nurses come down, right? We're ready to give TPA. Oh, it's a bleed. And everybody just leaves the room, right? And who owns it, right? And so that led me to feel like this guy. Now, I don't know if any of the audience today knows who this guy is, but this is an actor named Peter Lynch, and he starred in a movie that won the Academy Award in 1976 called Network. He was a newscaster, and he basically was losing it because of American society, which, still happens today. And he had this catchphrase, and he goes on camera as a network news anchor, and he says, "I'm mad as hell, and I'm not going to take it anymore." And that really is the spirit of the Code ICH movement. This is what we wanted to do. And part of it comes from the fact that we felt that meaningful change was actually being too slow to come. And we wanted to move the process along and stimulate and get people to act as advocates and champions for cleaning up our act in the way that we as teams, because everyone knows, like, stroke is a team sport. No one person can do it, but teams need leaders. And that's actually what I'm hoping you guys can do after listening to this webinar tonight, is do some thinking, do some reading, have some conversations with your colleagues, whatever realm you're in the stroke universe. Talk with your intensivist, your stroke neurologist, vascular neurology, neurosurgery, and of course nursing, and all the other allied professions that we function together with in a stroke center. And let's try to do better for ICH. So this is actually what the paper looked like. The authorship group was really kind of cool. And they're what I call ICH nerds. These are, you may recognize some of the names, but these are people that have actually devoted their careers, their research careers in some cases, to studying ICH and trying to do better. It's a global group representing 8 different countries around the world. And it's the deadliest and most disabling disease, and stroke certainly one of the worst in the world. But our protocols and our quality metrics have far lagged behind what we take for granted for acute ischemic stroke. And that's what we want to do. So when Dan did the introduction and he talks about the Code ICH group, we're not some kind of formal organization. We're actually a grassroots movement of people that care about this disease, that want to lead and feel that we can do better in our own hospitals and in the hospitals and our healthcare systems, and to be quite honest, in hospitals that serve stroke patients throughout the world. So we feel it's time to define and we have the evidence now, and it's time to implement performance-based measures. And what we decided together, we had the concept and we're thinking, well, what do we want to improve? What are we going to do? And we really focused on time is brain. And we looked at what do we all do all the time? Well, we control blood pressure whenever it's high, but no one's holding us to task about how quickly to do it. Why the disconnect? And when people are on anticoagulation, right? And I'm not talking about antiplatelets. I mean true, DOACs or vitamin K antagonists, blood thinners. We know we want to reverse it. But, for me personally, being witness to the sort of clown show of how we disorganized we were about doing it, I realized, I want to do this for my hospital, for my system, for all the hospitals and all the stroke centers. And so now we're going to go through the data about why we think we're ready to do this. The take home of this group, which met several times in 2023, reviewing the evidence, we determined that we have enough good evidence to basically make an aspirational goal of beginning parenteral antihypertensive therapy within 60 minutes of hitting the door. Even hanging or beginning an emergency reversal agent for anticoagulation within 60 minutes of hitting the door. Next will probably be studying and benchmarking and figuring out effectiveness measures for actually attaining blood pressure control to our desired target as we continue to standardize that, and for attaining documented emergency reversal of anticoagulation. But we felt like this was the lowest hanging fruit that we have now at that point in time. And the paper was published online in December of 23, in print February 24. And I'm happy to tell you that if you follow the literature, there's really been a wonderful kind of surge in research and interest in ICH. And in just a lot of centers looking at, there's a new publication I'm happy to be part of in Neurology, which is a multi-center study. Just how good are we at attaining, beginning antihypertensive therapy, reversing anticoagulation? We're starting to develop a good literature on the benchmarks. And the next step is going to be, how can we improve? So that's really, it's really kind of a global performance improvement project or a quality improvement project. This is a slide lent to me by Tom Brott, a legendary stroke researcher, if you're not really familiar with him. This guy actually invented the NIH stroke scale, along with a few other people. But it's sort of meant to illustrate the crucial role of volume in ICH prognosis and outcome. So you see the ping pong ball is 28 mLs. So that's almost 30 mLs. And this is an old classic study by Joe Broderick, who's also a giant in stroke and a good friend, published, as you can see, quite a while ago, over 30 years ago. And you're really plotting out the outcomes here, right? Full recovery on your left, dead on the right, lots of dead people, against ICH volume. And the paper was called, right, ICH volume, a simple predictor of 30-day outcome. And what the slide shows is that if your bleed is 60 mLs or higher, you're virtually assured at that time point anyway. They weren't doing decompressive craniectomies in those days, but you're probably going to die. And if you don't die, you're going to be bedbound and disabled. This Oxford handicap scale is very analogous to the Rankin scale, by the way. If you're below 30 mLs, you might die. You might end up being disabled and bedbound, but you can see at least the positive outcomes are possible. And this really predated and was a predicate for what we all know and love, the ICH score, right? And you see at the top of the list, these are in multivariable studies. These are the variables or factors that again and again and again seem to independently predict not only mortality, but also functional outcome, right? Bigger bleed above 30, lower GCS score, infiltratory location, significant intraventricular hemorrhage, and older age, specifically age over 80. So we know that if you get a scan, someone presents acute hemiparesis, change in mental status, maybe vomiting, right? And they come in, and if you scan them within the first couple of hours, in this study, the first 3 hours of symptom onset, right, you can see significant hematoma growth when you get your next scan, your so-called stability scan, a few hours later. And this was a patient that I treated as a resident at Harlem Hospital when I was training in New York City. And so the classic study here found, when they did the follow-up scans, they found substantial hematoma growth in 38% of ICH patients if initially scanned within 3 hours of onset. And you can sort of see here that this is the change in hematoma volumes of the patients that did go on to grow or expand their hemorrhage volume. So what we've learned is that there's this early window of about 3 hours plus or minus an hour, where if you get to patients fast enough, they have active hematoma expansion. And we know from other studies, that this incremental hematoma growth significantly contributes to poor outcome even after accounting for the baseline hemorrhage volume. So I want to talk next about imaging, right? Because imaging obviously is so key and so important to pulling the trigger. So it's almost like people come in as an undifferentiated stroke, and then when you see the blood, that needs to trigger a secondary alert to the code ICH team. The code ICH team is a little different, right, than the code stroke or code AIS team, right? Because you need your open neurosurgeons, your open neurovascular neurosurgeons involved. You don't necessarily, for an acute alert, need your angiotechs, for instance, like you would when you're notifying your team to mobilize for a thrombectomy. And so I think that imaging plays a really, really important role. Obviously, we all know it does for standard ischemic stroke. And this is just to highlight a paper that I did during my 4 years in Michigan in Henry Ford Health System, where we implemented and we simplified, and what I like to say is we militarized the imaging protocol. It was like, this is what we do. Everyone gets, right, they say it's a code stroke, everyone gets a CT angiogram. And nowadays, obviously, CT perfusions as well to look for late window opportunities to diagnose and treat LVO stroke. And I think the future is going to hold that this is where we are going to go for ICH. I'm going to highlight a little bit about what's happening, what I think the future holds. But in this paper, we did a classic before and after, right? And after implementing CTA for all, we diagnosed way more LVO strokes, we treated them faster, and we got better outcomes at a system level. Right? Well, basically just rethinking our ideas about, well, how are we going to image strokes, right? And so I think that this is what's going to be happening next with ICH. So everybody recognizes this in the audience, I would imagine. All right, this is a RapidAI output showing your penumbra and your core, and we can use this now to select patients for intervention. Well, the good news is that there's new technology now that's coming. It's in progress, and I think it's only going to evolve and get better for ICH. So if you're not familiar with it, this is the classic CTA spot sign, right? You do a CT angiogram, right? So CTA for all. If it's a bleed, great. Now we have a CTA. And you can see active contrast extravasation into the hematoma bed itself. And we know that this can be predictive of further hematoma expansion. Now, we don't have an approved hemostatic agent yet, but like I said, with the fastest trial, we're working on it. The only thing I'd say, though, is that a spot sign has way more meaning, prognostic meaning, in terms of predicting hematoma expansion the faster that scan's obtained after symptom onset. Because those spot signs linger, but if you're getting your first brain image 6 hours after onset, even if you pick up a spot sign, it's like a infiltrate on a chest x-ray, that patient's out of the active bleeding window. So just something to be mindful of. And there's also a lot of really interesting, fascinating, and very promising data coming through about non-contrast characteristics of CT scans that seem to be predictive of ongoing or active bleeding. And there's a lot of names for them: blend sign, swirl sign, black hole sign, irregular clot morphology. The bigger the hematoma is, right, depending on how quickly you can get it, something called hematoma growth velocity. And radiomics and image analysis and AI hold the promise to be able to look at this and effectively one day, I believe, give us some kind of a numeric predictor of giving patients risk of active bleeding and hematoma expansion. And I think that in the future, that's going to inform our therapeutic decision-making as we develop better hemostatic interventions for ICH. And that's the future, but this is what we actually have now. So I want to just highlight a bit of this, moving from left to right. There are now already modules that run algorithms that can immediately detect the presence of blood and notify you and your team on a cell phone, just like it immediately notifies you for suspected LVO. This algorithm is available now with extremely high sensitivity and specificity. Similarly, in the realm of hemorrhage, they can detect and notify you immediately of extraaxial collections, not even just the acute blood, but the subacute subdurals that we see, and even the chronic subdurals, which is also really important if you're building a hemorrhage program, particularly now in the era of MMA embolization for the treatment of chronic subdural hematoma. Here, the analytics can actually immediately calculate a hemorrhage volume. So you see this bleed in red here. It's been thresholded, measured using 3D planimetry, and it's calculating an ICH volume of 73 mLs, right? So probably in all probability that ABC2 metric that we use to estimate hematoma volume one day will become a historical artifact. And the imaging will be able to do this immediately and help us triage patient flow within our healthcare systems. There are now automated algorithms to calculate with great accuracy midline shift, as you see here, to detect and quantify obstructive hydrocephalus. That's not Ohio, it's obstructive hydrocephalus. And then there's a new module in development called Rapid Delta Fuse, which I'm going to show you in a minute, which is going to be really interesting, mostly for use in the ICU. This is a case study of one medical center in Nebraska called CHI Health. And they actually implemented in early 2003 these ICH detection modules, and they were able to quantify an immediate improvement in ICH score compliance as a quality metric. They were able to identify more ICH patients that were being transferred down to their main hospital for neurocritical care or possibly surgical intervention, speeding the placement of external ventricular drains. And they also, because the patients were basically moving in through well-oiled machine, a stroke program, right, not being kind of written off as nothing to do, call palliative care, they were able to document significant reductions in length of stay. And this, they felt, helped their hospital achieve the status of a comprehensive stroke center. And here's a very similar set of data. This is from another hospital in Michigan called Corewell. And they, again, implemented their ICH detection software, volumetric calculation software, and similarly, were able to identify more ICH patients, get more to the hub for intervention, and we're able to document a reduced length of stay. So just the beginning, very promising. And these are centers that I call early adopters, but I think this is the wave. This is the crest of the wave of the future. Delta Fuse, I think, is going to be mostly a neurocritical care kind of imaging technology. And what it does, you have your prior scan in the center here. You see these hygromas bilaterally. And then something happens and the guy gets worse. And now you see this big subacute on chronic subdural about 1.5 centimeters plus on the right side in the midline shift. So the Delta Fuse actually co-registers both scans based on the raw data. So you're not like trying to line up different slices, and can basically give you an image that shows the change before to after. So it's colorizing here in blue the chronic element of the right subdural hematoma. In red, it's colorizing the subacute to more acute component. It's actually showing changes in ventricular configuration. So in here, the powder blue, that's where the right ventricle used to be. And now you can see it's been pushed immediately. So a lot of really exciting new technologies coming in the whole area of imaging for ICH. I'm going to keep going and talk a little bit more about medical management. Blood pressure control we discussed. Here, red line is autoregulation at work. We know many of our ICH patients are chronically hypertensive and shifted to the right. But we also know definitively that when the brain is socked and blasted with arterial intracerebral hemorrhage, there's vasoparalysis that happens. In other words, loss of autoregulation. What this means is that relatively what you usually consider a minor drop in blood pressure can slip the perihematomal brain into the zone of ischemia. And if we're not controlling blood pressure well enough because of vasoparalysis, right, we can exacerbate that swelling, that angry swollen brain that I showed you at the start of the talk. And that can exacerbate cerebral edema, tissue injury, and ICP. What that means is to manage blood pressure in ICH, we're what we call living on a thin line, right? We don't have a lot of margin for error. And we really want to we want to use our technology to control blood pressure within relatively narrow ranges. And the best way to do that, in my book, is using nicardipine and clofidipine. The calcium channel blockers is first-line treatment. And again, I have no ties with them or anything else. But that's how we do in our stroke system. We actually use nicardipine, although two of my other systems, we had both, and we used clofidipine. They're both dihydropyridine calcium channel blockers. They're very fast acting, and they're very reliable without a lot of overshoot or undershoot. Now, there's a lot of studies showing that the INTERACT-2 and ATACH-2 trials compare 140 versus 180 as systolic targets in acute ICH. And there's a number of different analyses showing, like this one. I think this is the best one, and this is Qi Li. Qi Li is a stroke neurologist and researcher from China. He was the lead author on the Code ICH white paper. He did a research fellowship with Josh Goldstein, as you can see here. And what he found was that overall, right, the lower blood pressure target intensive didn't relate to improved outcomes. But when he looked at the subset of these ICH patients that got their blood pressure controlled within 2 hours, then now you see a big expansion of the more positive ranking outcomes, right? 0, 1, 2, and 3, right? Which you're not seeing if the blood pressure is controlled later. And on the weight of all this accumulated knowledge and evidence, that's what led the Code ICH group to say, you know what, we really should not dilly-dally, and we should get serious about what we're doing and hold stroke programs feet to the fire and measure how quickly we can start and attain control and make that a stroke quality metric that everybody just takes for granted. In terms of emergency reversal, it's an interesting story. It's approaching 20% of our ICH patients now are AFib or VTE patients on various forms of anticoagulation. We know their risk of active bleeding is even higher than 38%. It approaches 50%. And the window for active bleeding is longer. It's not 2 or 3 hours. It can go on for hours and hours and hours. And the mortality rates have conventionally been terrible. Not 33%, 50%. So we all know we want to reverse anticoagulation. This is an interesting paper, actually from Europe, coming out of Germany, where they took people on warfarin-associated ICH. Now, fewer and fewer of our people are on warfarin these days, but when they looked at their data set, they found that if they were able to document normalization of the INR to less than 1.3 within 4 hours, there was a big reduction in the odds of ICH enlargement, as you can see here. And you see it's a linear effect. The faster you can reverse anticoagulation, the less risk of active bleeding into the brain. And then after Code ICH paper came out, Kevin Sheff and colleague immediately got to work and looked at the Get With The Guidelines data set. They didn't have door-to-needle times for blood pressure, but they did have it for emergency reversal. And they found the median door-to-needle time for starting a reversal agent was 82 minutes, right? So we're now saying we have to really all fight and work to get it to less than 60 minutes. And basically what they found was that the patients that got their door-to-needle time less than 60 minutes had significantly reduced mortality compared to those where it took longer, right? No effect on functional outcome, but mortality is still a pretty good hard outcome for ICH, given that a third of patients die. And you can sort of see the histogram here of their door-to-needle times here, right? And we all see it. We all get it. Like, you know what? If we really put our minds to it, we can do better. In terms of surgery, we've all seen individual patients go for crani. This is an old patient of mine. Guy did great, right? He got, he was extubated on post-op day 2. We all see that. We know that the open trials, Stitch and Stitch 2, failed to show a benefit. But the thinking is that they went out to a 72-hour time window, and there's probably too much dwell time for the blood to sit in the brain and do all its damage to the surrounding brain tissue. So that needs to be modernized. And the main way we're modernizing now is using what we call MIS, or minimally invasive surgery. This is my friend, my former colleague in Mount Sinai, Chris Kellner, and they're doing a minimally invasive surgery. They've actually got an endoscope right, through a burr hole into the hematoma cavity, right, placed stereotactically, and they're doing their procedure called scuba, which is really water irrigation and suction. And when you're done with that procedure, you end up with your scope in an empty white cavity, is what it looks like. Sometimes you see a little bleeder on the wall of the cavity, and they actually are able to cauterize those. And his group was able to do this meta-analysis of a variety of different minimally invasive surgery trials, showing the accumulated evidence is actually positive. Although you see a number of negative studies here crossing the 1 odds ratio here. But it is, compelling and notable evidence, which brings us to the ENRICH trial. So ENRICH is a landmark study. This trial was stopped. And the story is they were randomizing both lobar or deep anterior basal ganglia ICHs from 30 to 80 ml, right? And then what they did, they looked at 6-month Rankin outcomes. And they basically do their procedure with something called an endoport. So it's bigger. You see the way this looks. It's like a big fat trocar. And they do it transsulcally, which means they're trying to go in parallel to the white matter fibers by getting and inserting in through the sulcus of the brain. And they had a significant result. In an interim analysis, these guys here, right, this is the treatment effect. To the right is better. No effect on the basal ganglia bleeds, and they stop randomizing them. And the red one here, right, shaded in pink, these are the lobar bleeds. And in an interim analysis, they were going to go on to 500 patients, right? The data monitoring committee said, stop, you have a positive study. And this is now triggering an awful lot of interest in setting up ICH programs. So ICH programs can focus on using ENRICH criteria to offer surgical intervention for the larger lobar bleeds. It can focus on other emerging promising therapies, such as continuous ventricular irrigation for bad IVH, either with or without a low-dose thrombolytic involved. It can stimulate referral to a neurocritical care unit for multimodality brain monitoring, and all this good stuff. And if you think about it, if you want to build your ICH program, right, how cool would it be to get immediate notification of a lobar hemorrhage with a volume that falls between 30 and 80 mLs? And now you know they meet the criteria for ENRICH, right? And then rather than phone calls and maybe getting a telestroke consult and and then getting on the phone to see if neurosurgery is interested, you've all decided, no, these guys are coming down now. We'll actually do the stroke evaluation when they arrive. We need the ED to work on the airway, the blood pressure, make sure the transfer is safe, get them down, copter them down, whatever we have to do. And this is exactly the kind of visionary program that we're working on in the Westchester Medical Center Health Network now. And this basically shows, this is just a histogram showing ICH volumes at one program, and you can sort of see here, see where I assume you can see my arrow. Those are the ENRICH candidate patients. It's about a full 20%, right? And we're missing them all now, right? If we're not doing this kind of immediate detection and analysis, right, they're languishing. And this is how I think we can really use this to fire up, if you will, system-wide comprehensive ICH programs. I'm going to end just talking for a minute or two about bundled care for ICH. Now, care bundles, if you don't know, and again, I always find it interesting, we just take for granted now, oh yeah, you get your scan in 15 minutes of hitting the door of the ED, right? And then, we're targeting to get you on we diagnose your LVO and all this and that, la. But the progenitors of this, right, was a program in Helsinki, Finland. And they basically were trying to speed their door-to-needle time for TPA. Until then, we were really pretty bad, right? In the early decade, the first decade of TPA approval from late 90s to the late noughts, 5% of ischemic strokes were getting any IV thrombolytic. Now pretty much standard of care, state-of-the-art, is around 15% minimum, if not more, depending on your population. And the door-to-needle times were bad. And so I liken this to like the lean processing, right? Like how can 5 guys change 4 tires on a racing car in 18 seconds? Like it doesn't seem possible. But these guys in Helsinki figured it out. This is, the black line is their door-to-needle time in 1998, right? And you can see it's well over, I mean, it's approaching 2 hours. And you see every year they kept doing iterative improvements and their door-to-needle time goes down, 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 right? And here we are now, right? When they published, this is an old paper, it's 2012 in Neurology, they were reporting consistent 4 years in a row, 20-minute door-to-needle time for giving TPA for acute ischemic stroke. And this is obviously before the whole LVO revolution of 2015. And right, and what did they do? They cut out the unnecessary stuff. They were like getting chest x-rays and EKGs. Nobody does that anymore. You know, they had the EMS bring the patient. They weren't, unloading them off a gurney onto a stretcher and eating, putting them back on a transport gurney. They said straight to CT. They were getting the history by cell phone, right? With pre-hospital notification. So they were already ready and they knew the story when the patient arrived. So care bundles can be very powerful. When we were thinking up the code ICH concept, we came across this paper. It's called ABC ICH by a British vascular neurologist named Adrian Parry-Jones. He had the same ideas. And in his one hospital, right, he basically created a care bundle with specific time targets for emergency reversal of anticoagulation, blood pressure control, and he had some other features in there as well. And this is the survival curve at his center before implementing the bundle, right, during implementation, and after. So with this bundle, they documented a significant reduction in mortality of these patients. I think that the reversal of anticoagulation, blood pressure control is an important piece of it, but I think the other thing are the intangibles, that they were focused on this. They weren't given up from the get-go, and they were basically rejecting the shroud of therapeutic nihilism, the oh well, or like that, whose job is that? Is that neurosurgery's job or whatever? They tackled it and they did it. And when you have a team of people that actually believe that they can make a difference, even with a disease as deadly as ICH, you can make a difference. And then, incredibly, as our paper was getting ready to be published, this paper, Interact 3, was published by Craig Anderson and colleagues. Now, if you know Craig, he's an Aussie, and he does most of his multicenter trials in Asia, particularly China. And he had the same idea again. We're going to do a bundle. We're going to aim for blood pressure less at 140 within 60 minutes, reversal within 60 minutes. They also had fever control normal glycemia, which actually not a lot of the patients had. Most of it's actually the blood pressure intervention, 70+% of the time. They brought hospitals in succession using a stepwise approach. And then they basically split the patients if they were admitted to a hospital that had implemented the care bundle versus those that were at a hospital at a certain point in time when they were getting usual care. And they were able to document a significant improvement in the Rankin shift, the ordinal Rankin shift at 6 months by implementing these care bundles. And I can tell you, somebody who has experience, having any trial of any kind that can actually work and help in ICH is always a significant achievement. So anyway, Code ICH, to wrap up, is an aligned pathway right? And we want it to be an enduring platform. We want people to use the terminology, think that way, and build teams around it. And the hope is that as more data comes down the line, we will implement more and more quality metrics so we can even the playing field, if you will, and take ICH just as seriously as we're all used to doing for acute ischemic stroke. So thanks for listening, guys. I really appreciate it. If you want to learn more, we do have a research and education website. It's www.code-ich.org. This is an excellent learning platform. There's a number of great videos and interviews of a lot of the Code ICH authors digging into the various subtopics of surgery, blood pressure, what about antiplatelet therapy? What about ventricular drains, osmolar therapy and all that good stuff. So for one of the most deadly and disabling diseases in the world, we're all working, and we want to work with you to make a difference. Thank you.
That was great, Dr. Mayer. Thank you so much. Really great content, and your passion for ICH care is evident. I especially loved your reference to the movie Network and the phrase, I'm mad as heck and I'm not going to take it anymore. Now we'd actually like to open it up for some Q&A. If anyone on the line has any questions that you want to ask of Dr. Mayer, please feel free to use the chat box on your screen. And we have a couple of questions here. Let's see, first question. So if you had to predict the future, what do you think would be the biggest change in acute hemorrhage management that you predict will be driven by the principles of Code ICH and advances in AI technology?
Yeah, well, I think it's a no-brainer that it's the AI imaging technology is going to be broadly implemented. It only makes sense. And I think we're going to I don't think we have all the answers yet about how the care algorithms are going to change. I think we're going to be doing a lot of surgery, actually. And I think the other thing is that I can't talk about the fastest data right now. There's some general general announcements. I don't know if you know, but the trial is on pause. And I can share that the reason it's on pause is that we were able to find out that there's an optimal responder group to the factor 7 therapy, recombinant factor 7A, and it's all based on imaging. It's all based on imaging. So more to come, and we're expecting some publications to come, in the upcoming months and everything else. So I think we're going to be using the radiology for patient selection, for medical therapy interventions, get the right patient to the right place at the right time, so system-wide triage, and then expanding surgical programs. I personally think that we're going to end up also, there's going to be more ICH surgery trials. In Enrich, if you're familiar with it, that minimum volume of 30, I think it's too big for deep basogangliar thalamic hemorrhage. And there's just too much damage done at the outset. So I think we have to start to target the smaller deep bleeds. And then there's also emerging data about how if you can really affect a large reduction in the hemorrhage volume at the end of the case, those seem to be the people that do best.
Yeah, great. We have another question here. Do you think it would be helpful to have AI help with future surgical and hematoma expansion prevention trial enrollments?
Absolutely. Yeah. I think right now, what we're left with was, just get it faster, faster, faster. That's why it's called fastest, right? So the inclusion was, in the original factor 7 trials, then the FAST trial, it was 0 to 3 hours from onset. So then in this one, it was shaved down to 0 to 2. And what we're finding is that even that we can improve on. And based on certain imaging features, we can find people that are really, really very likely to be actively bleeding into their brain. And so in order to move like a 90-day or 180-day Rankin scale, right, at least to start, you really have to be really choosy. You don't want to be giving these agents that have side effects, right? Stroke, thromboembolism to people that are done bleeding. It makes no sense. So, I mean, yeah, I think the imaging is going to trigger it all.
Yeah, great. We have another question here. Will this PowerPoint be available after this webinar? The recording of this webinar will be available on the RapidAI website within a few days. So if you're interested in seeing this content again, you can access the recording after the fact. Let's see here. We have another question. We discussed anticoagulation in ICH, increased severity of bleed and poorer outcomes, etc. What about antiplatelet therapy? Many on aspirin or those on DAPT. Any particular nuance around this aspect?
Yeah, sure. So basically, there's a lot more people on antiplatelet therapy than anticoagulation. It's quoted to be about 18% anticoagulation, but it's got to be at least 40% plus, right? Well, yeah, we're at an interesting point. The best data we have is the patch trial. This was a Dutch study where they had spontaneous ICH on one or more antiplatelet agents, and they randomized half to receive platelet transfusions and half not. And they stopped the study. The Data Safety Monitoring Committee stopped the study. They were thinking that patients who got platelets would bleed less and do better. But what they found were worse outcomes, significantly worse outcomes in patients that received platelet transfusions. We don't have the granularity to know why, but the data is, so the guidelines say that if you're giving it for the purpose of pure hemostasis, platelets are not effective and may be harmful, and don't do it. The exception is if they're going to have a drill through their cranial vault. So if they're going to get a ventric or craniotomy, for whatever it's worth, the neurosurgical community is like, I want to reverse them. And I kind of get it. I understand that, right? Because that's a subset of patients that weren't even included in patch. So we don't know. But, we call it belts and suspenders. Like, we just don't want to see any intracranial bleeding or hemorrhage. Now, desmopressin or DDAVP, from my vantage point, we use it every time. And it seems to be very widespread. I actually don't recall where it stands in guidelines, but I know it's benign, right? You never see anybody have a bad reaction. It causes a one-time release of von Willebrand factor on the surface of these inhibited platelets that can enhance their ability to activate and help formation of clot. So that seems to be a sort of unofficial standard. But that's what I know about antiplatelet therapy. The other thing I want to say, though, is you guys may see this too. I was interested in doing some of my research to find there's actually no true level 1 indication of any kind for using antiplatelet agents in combination with full anticoagulations, like rivaroxaban, apixaban, or warfarin. The only exception seems to be if you're AFib and you're on one of those blood thinners and you've got a stent. In which case, most people say, okay, not DAPT plus anticoagulation, but at least we'll put you on single antiplatelet therapy. And I kind of get it, you know. But all these studies that look at bleeding rates, right? If you're on antiplatelet therapy and anticoagulation, it's better than if you're on there's more bleeding than, spontaneous bleeds occurring than if you're on anticoagulation alone. If you're on DAPT, it's even higher.
Great. Let's see, I think we have time for 2 more questions. The next question is, what are your thoughts on temperature goal 37.5 and below target used by Interact 3 and FES bundle trials as part of the ICH bundle?
Thank you. Great question. My opinion is that, first of all, intracerebral hemorrhage causes a lot of central fever, what we call neurogenic fever, not infectious. Blood in the ventricles, even more, and that's well documented. But this battle is not being fought in the first hour presentation. This is actually, that's a protracted, drawn-out process in the intensive care unit. We have the Intrepid trial, which looked at immediate early fever control with a surface cooling system, the Arctic Sun, and it had a neutral result, didn't help, didn't hurt. We know that actually the active fever control, if you're not controlling shivering well, can actually be detrimental and be stressful to patient, increase metabolic rate, hyperventilation, tachycardia, right, just from uncontrolled shivering. And that being said, if you've got the right protocols in place and you've got effective cooling therapy, right, that's our standard of care, right? We have we don't tolerate prolonged sustained high fevers, whether they're neurogenic or not. We just don't. And there's some anecdotal evidence, including some stuff I published, that treating fevers in acutely brain injured patients actually can help improve mental status, and that the fevers actually depress level of consciousness.
Yeah, wonderful. Let's see, I think last question. You had mentioned the importance of getting out in front of hematoma expansion, and even the Enrich trial has a 24-hour time frame for their inclusion criteria from symptom onset. For centers that want to implement the Enrich protocol, what do you think is the right surgical clock for minimally invasive surgery? What's a realistic door to port placement time that neurosurgical teams should target, in your opinion?
Love it. Great question. I'm a big believer. I think that the positivity we saw in Enrich is because they were getting in there early. I believe blood is toxic to the brain. The longer it's allowed to be in there, the more it's going to do its bad stuff, right, to surrounding brain tissue. So at a minimum, you have to get a 6-hour stability scan to demonstrate that you're not actually grappling with an active bleeding process. I would say that the optimal time then, once you've developed documented stability 6 hours, is probably around 12 hours. I mean, out to 24 is fine, right? But I think that when you think about the logistics of organizing the surgery, and remember now, but here's what we're figuring out. We're now creating a new neurosurgical emergency, like middle of the night surgeries, right? I mean, we all take it for granted for thrombectomy at midnight, right? Acute 2-centimeter subdural at midnight. You got to go in. You got to do it, right? ICHs have never really been like that. No one's been running, In fact, and for us, like for me as a neurointensivist, it's like, well, this surgeon wants to operate in ICHs. One of my other colleagues, both great people, don't want to do it, So now we realize, wow, we're stressing the system a bit now if we're going to really make this a neurosurgical emergency. But I know it can be done, and I know that from working with Chris Kellner at Mount Sinai West in New York, because that's what they've done. And they actually do these surgeries, right? The MI, because he's an open nerve surgeon, endovascular guy. They do them in the angio suite, actually, interestingly, because they have better access, right? They control that. They're not fighting with other services for OR time.
Yeah, and if you're looking at those stability scans to determine whether or not the hemorrhage is done bleeding, technologies like rapid hyperdensity and rapid delta fuse should help you to make that call very quickly, right?
Absolutely. Very. Yeah. And then also like the delta fuse, like, did that aneurysm rebleed or not? And everyone's got a different opinion, but it's sort of like pupillometry now. Like no one's guesstimating what a pupil diameter is anymore. You're like, oh, it's 3.73 millimeters with an NPI of 5, or whatever. So yeah, medicine's getting better.
Yeah. Wonderful. Well, I think we're at time here this evening. Thank you again for joining us today as we explored the evidence surrounding diagnostic and treatment approaches to ICH. We appreciate your time and engagement. And if you're interested in learning more about our hemorrhagic solution or about Code ICH, please reach out to your local RapidAI rep or the Code ICH website and simply fill out the Contact Us page on the websites. Thank you very much.
Thank you, everyone. Have a great evening.